the University of Arizona Bio5 Institute, we bring together hundreds of multifaceted experts that include world-class bioscientists, engineers, physicians, and computational researchers. This team science approach is designed to ignite creative solutions to the many complex biological challenges facing our families and communities, and has resulted in disease prevention strategies, promising new therapies, innovative diagnostics and devices, and improved food sustainability.
Hello and welcome to another episode of Science Talks, a conversation hosted by the University of Arizona's Bio5 Institute. My name is Lisa Romero. The field of public health has become even more critical in the wake of the COVID-19 pandemic. Public health professionals must balance strategic thinking with compassionate thinking and must truly be able to collaborate on the state, national, and global levels. Today on Science Talks, we're joined by physician and scientist, Dr. Purnima Madhivanan. Dr. Madhivanan is an associate professor of public health, medicine, psychology, family and community medicine at the University of Arizona, as well as a member of the U of A's Bio5 Institute and Cancer Center. She's currently the director of the MCH program, as well as the NIH-funded Global Health Equity Scholars, or GHES, training program at the University of Arizona, and serves as co-principal investigator for the GHES consortium in collaboration with Stanford, Yale, and the University of California at Berkeley. She completed her medical training in India and received an MPH, PhD in epidemiology from the University of California, Berkeley, and completed her postdoctoral training at San Francisco Department of Public Health on clinical trials management. Dr. Madhivanan is an epidemiologist and biomedical researcher examining the intersection of infectious diseases and cancer using omics technology. Her current work is examining the vaginal and gut microbiome and their role in women's reproductive health. She's conducted several large mixed methods epidemiological studies in the US and internationally. With many accolades to her name, of note, Dr. Madhivanan is a 2007 winner of the prestigious International Leadership Award from the Elizabeth Glaser Pediatric AIDS Foundation for her work on HIV prevention. Dr. Madhivanan, so excited to have you joining us today. Thank you for being here.
Thank you, Lisa, for having me. It's my pleasure.
So I want to start with this because as a woman, in reading about your work and your past and your journey, you have been a champion for women and other disadvantaged populations, I think long before sort of most people would say that was even popular to say. I think that has been a tone for your entire, career and probably life journey. That's really important to me as a woman, as a mom that has daughters. And I wanted to, you've been doing that for over 20 years. And I wanted you to tell me a little bit about what started you on that path. What makes you passionate about that in particular?
When I initially started on this path, I was pretty much clueless. I went into medicine because my family wanted me to have somebody in the family with a doctor. I was first generation, first person in my house to go to college. I was raised by a single mom who had to raise 3 kids between the ages of 5 and 1 when my father passed away. So I have been raised by or surrounded by very strong women in my life. And then when I finished medicine, I wasn't sure which direction I wanted to head in. And it was around that time that I took a step back and just wanted to reevaluate what it is that I wanted to do. And during that time, I was part of this club called the Hash House Harriers. They say they're runners with a drinking problem or drinkers with a running problem. And during one of those events, a friend of mine said there is a doctor who wants help in taking care of her patients. I wasn't sure what she was talking about. And this was, not to date myself, this was in the late 90s. And I said, sure, I'll be happy to help her. And this was in a pretty urban city with some of the best healthcare facilities. So when I met her, she was actually running a HIV clinic. And this was during the time when patients were being thrown out of hospitals because of the stigma and discrimination associated with HIV. So she had taken voluntary retirement from her faculty position and started this NGO and was caring for these patients. And she had one male doctor, and that was it. So she wanted somebody else to help her along with this male doctor. And I said, I have a baby at home. I won't be able to work full time for you. She said, I'll find you somebody who can take care of your baby. Can you come in? And at that time, I was going stir crazy trying to raise a, take care of a baby all by myself. So any chance to get out of the house sounded really good to me. I said, sure, you find me a babysitter who will care for my baby and I will come and I'll help you for a few hours. Within a week, she found me an excellent babysitter who I think of as my soul sister now. Her name is Amsa. She did such an amazing job. Even to this day, I have such fond memories of her. And I went to the clinic and started seeing patients just for 2 hours a day. That extended to 3, 4, 5, 6, 7, 8 hours. And I was bringing work back home. And that's when my passion for medicine came back to me. And the reason was we had not studied about HIV in medical school. We had really not studied anything about social and psychological issues or cultural issues that can influence, social determinants of health that can influence a person's well-being. So the women who were coming to me in the clinic were in their late teens, early 20s. They had just gotten married and they had gotten pregnant and found out they were infected with HIV. Or they had their husband who had turned symptomatic was getting admitted in the hospital. So we would test the woman. Turns out she's HIV infected. Or we find that our patient had just passed away. And then when they come to collect the death certificate, when we test the wife, she's positive. All these situations, these young women, 19 to 23 years, maximum 25 years, and when the husband dies, the women were being thrown out of their homes because they would have just gotten married. And by that time, the man has already turned symptomatic, least understanding the natural history of the disease that he must have been exposed for a much longer period. But the event that took place was the marriage. So this idea that the woman has brought bad luck into the family. So she's thrown out. And the problem is this young lady now, who's a widow, cannot go back to her mother's house because she has other brothers and sisters who are in marriageable age. So there is a stigma associated with it. So these were the kind of issues I was seeing more than me being a doctor, helping them with their medical problems, cultural problems, social problems, issues that I had no control over and I didn't have any training for. And it was around this time that there were medical students who used to come to India to come and work with us for periods of 3 to 6 months. And one of the students mentioned, you should be thinking about an MPH. And I was like, what is this MPH? And then I started going and figuring out, this is all about prevention. I said, yes, this is what I need to learn. How can I prevent a woman from getting infected in the first place? Instead of waiting for her to get infected, get sick, and then come to us as doctors. How can I make myself unemployed so I don't have to be a doctor to deal with these issues? So I applied to the MPH program and I got accepted into Berkeley and I got my MPH. And when I was done with my MPH, I had this breadth of knowledge, but not enough depth that I felt I could independently do anything by myself if I moved back to India. So that's when I decided I need a little bit more training and got into a PhD in epidemiology, again, with the same plan of going back to India to continue my work. So I was doing my PhD in epidemiology, went back to India to do my dissertation research on the same topic, looking at upstream variables of how we can prevent HIV in the first place in women. So there were 2 papers that had just gotten published that looked at abnormal vaginal flora and how that can increase the risk for a viral infection called herpes simplex virus 2, which is a huge risk factor for somebody getting HIV. So my study was to examine the relationship of abnormal vaginal flora to acquisition of HSV2, and in the long term, looking at how we can do HIV prevention. That's how I got into this whole field. Nothing planned.
That is, I'm going to tell you, and I've probably done 30 of these conversations, and that is one of the best, I just think, most layered and rich origin stories of how you ended up where you are that I've heard. That's an amazing story. I mean, I knew a little bit of that, but not very much. And that's an amazing layered journey to take you to where you now are putting all of those things together, you know, and a different time and place.
Yeah.
But I think probably, you know, a lot of people we've talked to have said similar things in terms of, like, you know, I got all this great training, but I really still had no idea what in practice that would mean, right? And I think the people that I've talked to that have found the most sort of comprehensive human success is a story more like yours, where you're actually seeing what's happening in the world and with people, right? I mean, that's an amazing story, really.
Well, but I have to tell you, stories like mine don't make great researchers. We don't get grants.
Yeah.
We don't do the most sexiest cutting edge technology driven studies that, you know, funders are interested to fund us. So that's the downside to it.
How's that? I'm going to skip way ahead because that was a great segue. But I mean, how's that, you know, now as I kind of briefly said in the introduction, you know, public health took on sort of it became an animal unto its own being with a pandemic that we all faced, that, you know, nobody was probably completely prepared to face. Has that changed at all in the midst of, I mean, I think there was a lot of money being thrown at the pandemic, but I mean, in general, has that changed at all in terms of funding for this type of work? And
you know, when we think about public health, everybody thinks about this idea of surveillance and pandemic. Public health is more than just that. Yeah. And yes, we did see a lot of money being put into it, but not at the right time. And again, the challenges were trying to reach the people who needed it the most. It didn't happen in the right time.
Yeah.
So we still have those issues. We went ahead, raised ahead to get vaccinations, right? But we never for a moment thought, how are we going to roll this out in the community?
Yeah.
What are some of the issues we should be thinking about? So we completely ignored the social and behavioral aspects that we should have been studying simultaneously as we were developing the vaccines. So the problem we have is we go at one and we forget that there are these other factors that we should be thinking about. So we still haven't come to a stage where we're looking at this in a more holistic manner. We should be employing a systems approach to it. We're still being very siloed in how we do things. It's like I say, oh, I'm an epidemiologist, and somebody says, I'm a social scientist, and another one says, I'm this, I'm that. But we can have an intersectional identity. We can be a lot of things. And right. I think the problem we have is the funding agencies don't allow you to be that. So this is, again, calling out the funding agencies, is they want you to focus on one disease, one little thing in order for you to get funded. But when you're a practitioner, you have to think about all the other associated things that go with that disease. And I'm not seeing movement in that direction yet. And I hope it happens soon.
Yeah, I mean, I think it boils down to exactly what you said. You know, it seems to be we, as a society, as a country, as a world, and in terms of science and funding, we're so reactive, and instead of, like you're saying, this concept of planning and prevention and looking at different cultures in different areas of the world and how it actually comes to play. And that's too bad. I mean, I hope at some point, I mean, again, if a global pandemic doesn't even do it, it's hard to imagine what does shift that thinking. I hope that it starts to shift.
Well, I hate to be the bearer of bad news. We're going to start seeing more pandemics coming at a much more frequent rate now than before. It used to be once every few years. This is going to become more common now because we travel so much. We are so interconnected. I mean, think about the vaccines. We had so much vaccines here that I know for all the political reasons, we couldn't use them. But there were a lot of countries who did not have vaccine access even like till a year ago. And we thought we were so fully protected that we thought life is normal, we're back to normal. All it takes is for one person to get on that plane and come here.
Yeah.
So we are still looking at borders and working in these silos, unless we kind of think that every one of us in this world is going to be some way related to us. We are not going to be address some of these issues that we are seeing now, no matter how great the technology is. We have the best vaccines for COVID right now, but it's of no use if we are going to start seeing that the virus is mutating. You're going to see more variants. You can have any number of boosters in the US, but if a new variant lands up happening in Cameroon, we're all in trouble.
Right.
So I think we have to start thinking more globally along those lines.
Well, we need more of you and your story, and just, again, this perspective that is very unique, that allows you to see all that because of what you've witnessed and experienced. Yeah, that's scary and sad, and I wish that we could clone you, but we just have to keep talking. I mean, we can do as somebody not in that specific area, help talk about it, but we need to do much more than that. So let me drill down a little bit on, you're an epidemiologist. So talk to us a little bit more, us non-scientists and some of our listeners that are not familiar specifically with that term, what that actually means to the field of public health. And, just, what kind of groundwork do you need to do before you start using epidemiology to, sort of investigate a disease or a pandemic or something like that?
Well, if there is one foundational idea that underpins almost everything that we as epidemiologists do, it is to understand cause and effect. In epidemiology, demonstrating causality is difficult. So we are very careful. If you ask any epidemiologist, they're very careful about using the word cause. It's a very loaded term. So we are very cautious about talking about causality because it's difficult. It's long and complex, natural history of many human diseases. And because we have ethical traditions that say we have to protect human beings, both in healthcare and in clinical trials. So epidemiologists always hold the attitude that all judgments about cause and effect are tentative. They understand that causal thinking demands a judgment and are always alert to the possibilities that chance, error, and bias can distort or confound these causal assumptions that we make. So the ultimate aim of epidemiology is to use the knowledge of cause and effect to break the links between disease and its causes and to improve health overall. So when we set out to understand something like a disease outbreak, like what happened recently, we have to first confirm the existence of an epidemic. Then we have to verify the diagnosis. Then we have to develop a case definition, a very specific case definition. And then we have to collate the data we have on all of the cases. And then we analyze these data by person, place, and time, which is the epidemiologic triad that we talk about. And then we develop a hypothesis. And then based on that, we do the data analysis. And then based on those findings, we implement control and prevention measures. And then we evaluate whether these measures have worked or not. So I guess my answer is we have very strong traditions and philosophical underpinnings and methods that serve as the foundation for our field.
And, you know, as you said throughout the data, I mean, I think sometimes people that aren't scientists, you know, just think things are, you know, the whole like smoke blowing up in the lab, and then suddenly an idea appears and, you know, this magic, right? And, you know, I think for, you know, epidemiology, public health in general, it is so much based on data and systems and analysis, and then redoing that cycle. And, you know, I think that sometimes people don't understand how much of that goes into science, or how much of it should go into good science.
Yeah. And one of the biggest challenges that we face in science is replication. We have this issue of lack of replicability of a lot of the findings. So one of the things that we always talk about is when you're doing your experiments, or when you're looking at something, before you can say something causes something, make sure that there's enough data and evidence that A causes B.
Well, and I'm shaking my head at that because, you know, so I'm a communicator, and I'm not a scientist. I'm in science communication. And so I am, you know, a huge consumer. I have to be a huge consumer of basically every type of media out there, from social media to mainstream media to science, you know, more scientific publications. And I mean, it is just with, you know, the incidence of social media and everything being an instant news or instant study that with findings, and then you literally in the same feed will see two things that completely contradict one another, and it's one little study, and then, but of course the headline is like, you know, supplement is going to give you breast cancer or whatever it may be. I mean, the fact that you just said that is just something I struggle so much with as a science communicator, because it's scary, the lack of, again, data and like you said, repetitive studies that lead to people believing something.
Yeah, I mean, a simple example was when initially around the pandemic, when the hydroxychloroquine study started coming out. My goodness, I'm on WhatsApp with a lot of doctors, and I started to get this, there was a barrage one night. Oh, this French study shows that hydroxychloroquine actually helps. And these are doctors. These are my colleagues who are talking about it, and everybody is excited. And then this was just a preprint. It was not even a publication. It was just a preprint. And people hadn't taken the time to go and look at how the analysis was done. And what was really evident was everybody in the hydroxychloroquine group who were terribly sick had been excluded from the analysis. Just that alone should have kind of gotten you to think, come on, these are not comparable groups. So I think one of the challenges we have is critical thinking. And if there's anything that we should be teaching our next generation, is not about you know, something else that they have to memorize or to, you know, learn. It is, how do you unpack something, and how do you use critical thinking to examine some of these issues?
Yeah, that actually leads me to another question I was going to ask you about in a perfect way. I mean, I think, again, just because of the in-your-face nature of this pandemic, everybody sort of now has heard of public health in some broad way. Again, not in the ways that you actually execute it as a public health, professional. But and so I think it's becoming a little bit more popular as a field of study for undergrads, graduate students. I mean, do you have that same sense? And I mean, you just gave one example of, what it does take to be a good public health practitioner. Do you see that trend? And are there other things that students should think about if they're, wanting to explore this area?
Absolutely. I would say we need a lot more people coming into this field, and some of the traits that we should be valuing as a public health practitioner is empathy. If you are not going to have that, there is no point in you working in public health. You have to have a sense of community, being able to engage with the community, understanding your community, where are they coming from, and how can you be able to contribute without violating some of the issues that they might have, or some of the norms that they might have. Which brings me to strong ethical values. You have to be an ethical person, and you have to be responsible. And public health is not a sexy field. There's a lot of no's and rejections. So you have to be motivated, and you have to believe and be passionate about what you do. And last thing I would say is you have to be curious. You have to be curious and be able to go and examine why is it that this particular community has that cancer cluster and not somebody else. So it's an exciting field to be in, and you can make anything out of it. I mean, here I am, I'm coming as a physician who hated medicine, but I love what I do now. And in terms of undergraduates, we need people from all walks of life, not just doctors and nurses and pharmacists. We need engineers. We need veterinary science folks. We need communication people. We need business people. We need people from all walks of life to be in public health. I think that's what is so exciting about public health, is it's very inclusive, and everybody has a role to play in it.
Well, I mean, any students that get to have you as a mentor or a role model in this area are very lucky, because I think you embody all of those things. And I know it's never perfect, but that's an amazing gift if you're able to mentor and pass that on to students, because I think, again, they're hearing a person who's lived this in the real world, and it's so important. Before I have to let you go, although I'd love to talk to you for hours, I do want to ask, you just mentioned cancer a little bit, and I know that some of your work today, is at that intersection of infectious diseases and how that correlates with cancer. And just because, again, such an important topic. And I think that's an interesting intersection that a lot of people don't understand. Can you talk a little bit about that and where you are in that work right now?
Yeah, absolutely. When you look at what the National Academies of Science, Engineering, and Medicine have said, is the pathogens that cause majority of the currently known infectious disease-related cancers are human papilloma virus, which is the one that I work in, hepatitis B virus, hepatitis C virus, Epstein-Barr virus, herpes simplex virus 2, and the other big one is Helicobacter pylori. Right? There are several other pathogens, including some parasitic worms that also cause and increase the risk of some of the cancers. So overall, infections are believed to cause about 13% of all new cancer cases each year, excluding the non-melanoma skin cancers. So infectious agents, what happens is they can raise the risk of human cancers with different mechanisms. Human papilloma virus, Hep B, and Epstein-Barr, these act as direct carcinogens by expressing the oncogenes that can inhibit the apoptosis and increase cell immortalization. In other words, that means these agents are effective on genome instability of cells and can cause the cell to grow out of control. Now, H. pylori and Hep C virus can cause long-term inflammation in the body. So this can lead to changes in the affected immune cells, and they produce immune mediators and inflammatory mediators, which then lead to causing cancer. So there's still a lot that we have to learn between the links of infectious diseases and cancer. So we are just at the tip of the iceberg right now. We're still trying to kind of figure these things out.
And I mean, you mentioned, you know, how one leads to the other, but the inflammation piece, and you know how much that is being shown to increase the incidence of not only cancer but brain disease and others. And I think again, we're so lucky we have people sort of working in this space that is a bit murky right now in terms of causality and connection, but I think it's going to end up being so important to us as you know, people and with our families that are suffering from these horrible things.
Yep. So I'm headed to India to work on an area related to cancer, but not at the biomedical side. India has a lot of doctors, and we export so many doctors that most of our healthcare providers here in the US are all Indian origin, right? The challenge we see in India is once a person gets cancer and they're treated, and once they leave the hospital, they have no services. They have no support services. They have no support groups. So I got a Fulbright Distinguished Scholar Fellowship to go, and what I'm going to be working on is trying to understand the psychosocial and community-based needs that female cancer survivors would have, because nobody's talking to them about their reproductive health. Nobody's talking to them about their self-image. Nobody's talking to them about how they have to live in terms of keeping themselves healthy. So I'm going to be focusing on those aspects, more of the social and cultural aspects of what it means to keep somebody healthy once they have completed the treatment.
Well, that's amazing. And we didn't even, you got ahead of me on the Fulbright. Congratulations, that's incredible. Well-deserved, and not only then well-deserved, but now what you're going to turn the opportunity into is incredible. So thank you, and best of luck, and just thank you for all you do and all you're doing, and this empathetic approach, and always sort of keeping people at the heart of science. We need a lot more of people like you, for sure.
No, thank you. And I want to thank University of Arizona, because I really feel comfortable here, and I feel I have enough people who I can work with. That's the other thing, having collaborators and having the opportunities. So I'm very glad to be where I am. So I want to make sure I acknowledge that.
Yeah, well, thank you so much. And thank you for your time today. And thank you to our listeners for joining us for another episode of Science Talks. To learn more about the Bio5 Institute and Dr. Madhivanan's work, please visit us at bio5.org.
Thanks to our listeners for tuning in to another episode of Science Talks. Continue the conversation with us next time as we learn more about the amazing science happening at the University of Arizona's Bio5 Institute.